Just sit behind the side and do the grand job. Okay, welcome everybody. Amy has just started recording this session. I can see some questions in the chat about some people having to not leave a little bit earlier or can't make it. So yes, it is being recorded. Tracy, where will the recording be? Will it be on the website?
It will go on to the YouTube site.
Okay, perfect.
Some safeguarding, yeah. We can send the link though. Okay,
perfect. So there we go. So the recording of this will be on the Safeguarding Partnership YouTube site, and yeah, either put the link in the chat or it will be sent out to everybody who's signed on. That would probably be the best thing. Okay, so if I start with an introduction. So my name is Cindy Dunkling, and I'm the designated nurse for safeguarding children for the Suffolk part of Suffolk and North East Essex ICB. And I'm also the strategic lead for our child death reviews in Suffolk. So we thought we'd have this webinar because of the tragic deaths that we've lost in Suffolk, but also because of the national picture and how this sort of fits and sits in with our safeguarding and with our partners, and also because it's something that we get asked about over and over again. So myself and colleagues are here today to take you through this. First of all, we're going to look at the national picture, which I'll be presenting, and then we'll move on to what this looks like in Suffolk. And each of our speakers will introduce themselves as we come to them. So if I can just start with an explanation. So sudden unexpected death in infancy. The definition of this is the sudden and unexpected death of a baby when there's no apparent cause of death, and it's called unexpected death in infancy, or sometimes referred to as SUDI. It also includes sudden infant death syndrome, or SIDS, and fatal sleep accidents. A baby can die of a SUDI at any time of day or night, but most die quietly in their sleep. SIDS used to be called cot death, and you might still hear it referred to as that in some places. Tracy, can I have the next slide, please? Thank you. So the NCMD is the National Child Mortality Database, and it's where all of our information and the reviews of child deaths get fed into nationally. And each year, sometimes more than once a year, they'll produce reports from the data that's been gathered. In 2022, they did a thematic report on sudden unexpected deaths in infancy and childhood. They looked at the period between April 2019 and March 2021. And in total, there were 6,503 deaths of children between 0 hours old up until their 18th birthday. And within that cohort, there were 1,234 sudden unexpected deaths where there was no immediate apparent cause. And if we divide that up again, of that 711 were under the age of 1. You should get a copy of these slides too, hopefully, Tracy. So you can see the link down there on the slide that will take you to the report. And I do recommend people having a look at it. Can we go to the next slide, please? So looking at those 711 deaths, where it was sudden unexpected infants who died under the age of 1, 70% of them were aged between 28 and 1 year old. And of those, 57% were male. Infant death rates were higher in urban areas and in the most deprived neighbourhoods. 52% were actually classified as unexplained, or SIDS, sudden infant death syndrome, and 48% went on to be explained by other causes. So it might have been that there was an underlying metabolic condition or cardiac condition that wasn't known about before. There was a higher proportion of unexplained deaths in males, so 64%, than in females, 36%. Could we go on to the next slide, please? So what do we know about the under ones? The unexplained deaths were strongly associated with low birth weight, prematurity, multiple births, larger families, admission to a neonatal unit, maternal smoking during pregnancy, young maternal age, parental smoking and parental drug misuse. The profile of vulnerability surrounding the birth characteristics was even more marked among those deaths that were never explained, that went on to remain, that were explained, that went on to be explained by another cause. So safe sleeping within this, 98% of the unexplained deaths occurred when the infant was thought to be asleep. And of those, 52% occurred while the sleeping surface was shared with an adult or an older sibling. 64 deaths where the sleeping surface was shared, 60% was the sharing was unplanned, and at least 92% were in hazardous circumstances, so co-sleeping with an adult who'd consumed alcohol or co-sleeping on a sofa. Of the 124 deaths that occurred during apparent sleep, at least 75% identified one or more of the following risk factors relating to the sleeping arrangements: being put down face first or prone, or side sleeping, hazardous co-sleeping, inappropriate sleeping surfaces when sleeping alone, and inappropriate items in the bed. If you could go to the next slide, please, Tracy. Following on from that report, this year, the NCMD have produced another thematic report that looks at vulnerability. And within that, they talk about unsafe sleeping. So here you have a chart that's within that report that talks about the vulnerability factors and the number of cases that those vulnerability factors were found and what proportion of those it relates to. So if I'll just quickly run through, so not following advice and guidance on safe sleeping, 78%, unsafe sleeping that was planned, 39%, unsafe sleeping that was unplanned, 20%, carer under the influence of alcohol or drugs, 39%, an inconsistent account given, 17%, co-sleeping, 51%, co-sleeping that was planned, 25%, co-sleeping that was unplanned, and the carer under the influence of alcohol or drugs, 15%. Inappropriate or unsuitable surface or situation, 64%. Co-sleeping on an adult bed, 31%. Co-sleeping on a sofa, 12%. Not following the guidance on positioning or wrapping, 18%. Position for sleep on the back, 34%, on the side, 7%, on the front, 7%. Position in which the baby was found on the back, 18%, on the front, 34%. And finally, the room was hot, so over 20 degrees, there was 12% of cases. So again, the link to that report is on here for you to be able to have a look. And now I'm going to hand over to Jackie Wood, who's our lead child death review nurse, and she's going to talk about the data and information from Suffolk cases. Thank you.
Hi there, everyone. I can just give a moment. I think there might be some questions in the chat. I don't know if anyone wants to put the hand up, or if they're happy just to us to pick out. I think there's a question there from Helen. It says, does inappropriate sleep surface / place include car seat / buggy? I think that's referring to the data on the previous slide, and I think when we're looking at inappropriate sleep surface, then absolutely, kind of car seat and buggies are two really good examples, the same as kind of like bouncy chairs, that they fit into that same kind of category in the data.
Yeah, I think including on there is also things like nest, and when you have a baby with the foam stuff around the edge of the cot, what they're called. I can't remember what they're called. But yeah, so lots of cushions, toys within the surface as well. So that's also included on that. We have had a case in Suffolk. Bumpers, thank you. Thank you, Wendy. My brain wasn't working there. We have had a case in Suffolk where, you know, the baby was on a pillow within a Moses basket. There was a pillow. We've also had sort of clothing used as a mattress where there wasn't a mattress. So, yeah, duvets, that kind of thing. Why is the rate for babies positioned on their back so high? I think it's because most babies are put to sleep on their back now. I think following the change in the guidance in the early 1990s or late 1980s, it was very clear that babies sleeping on their back were safer, and that message really went out there, and we saw a massive drop in the number of babies dying of sudden infant death, thankfully. So the majority of babies are slept on their back. So it's other factors that then we're seeing. So as most babies do sleep on their back, we will see a higher proportion of even those ones who die being on their back. But it may be something else like being on their back but sleeping on an unsafe surface, being on their back but co-sleeping with an adult who's taken drugs or alcohol. So that's where you can see that difference. Did you mention crying when put down makes a difference? I don't think I did. No.
Okay, well, so as I already mentioned, my name is Jacqueline Wood. Most people know me as kind of Jackie. I'm the lead child death review nurse for the team in Suffolk. And why I'm kind of here is just really to talk you through kind of what the Suffolk kind of data looks like. Oh, I think Lisa has just said someone's got their hands up. Thank you, Lisa. Just going to see. It's not showing on my screen. I don't know if anyone wanted to come in there. I can't see any hands up at the moment.
No, it's not on mine either.
Okay, no worries. So I'm here to kind of talk to you about the Suffolk data. I think a lot of you will find this really interesting. So happy for it to be interactive. Do put your hand up or put a message in the chat. I'm just going to ask Cindy and Tracy just to keep an eye out on that and just shout out to me if someone has got their hand up or has kind of mentioned something. So on the screen here, so what we're looking at is we're looking at a 4-year data set from October 2019 until October 23, so kind of 4 years. We're entering our 5th year in our child death review team, so we're looking at a total of kind of 12 cases today in this session that we've had in that 4-year age group. So what you can see here is in West Suffolk, we've had 3 cases, and these are babies that have been put to, they've been put to bed. It's been their final kind of sleep, and sadly they were found to be unresponsive either during the night or kind of in the morning. The next kind of category we've got there is East Suffolk and Waveney. Now, I know this is a bit of a tricky kind of divide for health. We divide our cases into West Suffolk and East Suffolk, which is what our team kind of covers, and then actually the Norfolk Child Death Review team, they kind of pick up the Waveney area. But for today, we're looking at the whole kind of Suffolk data. Now, as kind of I just mentioned, with regards to kind of health, we cover East Suffolk, but I'm aware that obviously for our other colleagues, especially kind of police and social care, that when we talk about East, I think that is actually the area covered that is known to most of you as kind of South Suffolk, and I know Waveney you look at kind of being North Suffolk. So just to clarify, West Suffolk, we're kind of looking at kind of our Bury, kind of everything kind of from Stowmarket kind of onwards up into that kind of Mildenhall, kind of Newmarket. Our East Suffolk is what we kind of know as kind of our our Ipswich kind of teams, and that surrounding area, and kind of Waveney being again for police and social care, what you kind of know as kind of North Suffolk. So just looking at these 12 cases, so our team and myself, we've got Natalie, and we've also got Bernie. We have responded with a joint agency response with police and social care to all 12 of these cases. So our team have been involved in these from the onset. So what that might mean is it might have been that we were with them in A&E when resuscitation was being attempted, and we would be there to kind of support the family and to support the staff. Apologies, I think someone just muted me. I don't know if that was an error there. So yeah, so as I was saying, so we would support these families sometimes from that onset in A&E. If it's happened out of hours or at the weekend, we would contact the family alongside our police colleagues on our next working day, and we would do a home visit, and we would be with these families from the onset. And we would stay with them throughout the child death review process, which can include all the review, kind of supporting them through the post-mortem process, kind of inquest, and taking to our final review panel, which is called the child death overview panel. So obviously today we're just focusing on the data. And this is so you all have an idea of what do these deaths kind of look like and what can we really learn from them. So as I say, we're looking at these 12 cases. We can see there I've kind of split it into kind of age groups. So we had 2 that were kind of under 1 month old. In the 1 to 2 month category, we had 3 babies. In the 2 to 3 months, we had 4 babies. And then under, between that kind of 3 and 4, 2, and then in the next category, 4 to 5, we had 1 case. But just to note that 1 case was kind of 4 months and 10 days. So actually they're all in that really kind of clear kind of age group. Look at the next slide, Tracy. So kind of looking at the age of parents, so you can see there that it does kind of vary. You can see between our kind of 17 to 18-year-olds, we've kind of got 1 mother and 1 father. This was this was 1 case of a mum and a dad in that kind of age category. I think it's important to note that none of these cases fell under the family nurse partnership. So we haven't had any deaths of any children that were under the family nurse partnership. However, really interestingly, this case that of the parents being 17 and 18, it was their first child, and actually a referral had been made, but unfortunately the family nurse partnership was at capacity at the time, so the referral wasn't accepted. So you can see in that 20-year category, we've got a total of kind of 2 parents. Really interestingly, and I've just kind of highlighted that in red, that actually we had 5 cases where the mum was 22 years old. So just kind of highlights that kind of that specific kind of age category that we had over this 4-year data. And you can see as you kind of move down where those figures are then more or less kind of 1 or kind of 2 parents of each of those kind of categories, but getting less as the parent kind of gets older. So just going on to the next slide. So obviously there's quite a lot here, and I just really wanted to talk you through, so just to understand it a bit more in a visual point of view. So kind of gender, so we've had kind of 7 males and kind of 5 females. This kind of sits in to the national picture, with there being slightly more, being males tend to be slightly more at risk of this sudden unexpected death in infancy. Looking at our ethnicity, the majority of the cases were white British. We had 1 from a mixed background and 1 which was white other. Kind of looking next kind of financially, kind of really just quite interesting. It's difficult to pull this data through in kind of really meaningful way, but every case were in receipt of kind of child benefit, and 9 of the cases were receiving additional benefits. Looking at the kind of the feeding, we had 9 that were bottle fed and 3 were breastfed. Moving down onto your housing there, you can see that the majority of cases, looking at kind of the 9, were actually in social housing. And when I kind of refer to social housing, that kind of includes, council properties, people in that kind of social housing, but including kind of the council as well. We've got private renting, and we had 2 people that were owners. Now, just looking at that private renting, obviously it's been recorded as that, but actually they that their housing wasn't suitable at all, and actually after the child death they were rehoused by housing, and they had been on the housing list for some time, but were renting really sadly a really poorly conditioned rental property with lots of issues. So looking at kind of the SID risk factors and co-sleeping on the final sleep. So bearing in mind this kind of 12 cases that we've got, that actually 11 of those cases would have scored as having a risk factor of SIDS, and only one case out of all those cases didn't have kind of any kind of risk factors present. And I think that's really important that we kind of keep that in mind as we go through the rest of the kind of the slides and the kind of the presentation today. And even more so that actually on the final sleep, so actually the co-sleeping, we were looking at 9 of those kind of 12 cases that they actually were co-sleeping with a parent on the final sleep, and only and then only 3 weren't. And breaking that down kind of a bit further here on these bottom kind of charts, you can see that I've just broken it down in kind of location. So looking at that kind of co-sleeping again, so we had 2 cases where they were co-sleeping on a sofa. We had 1 case where the baby was actually in a cot, which we know to be a safe place for a baby to sleep, but actually this baby was placed on their side, which we know it isn't kind of the recommended kind of guidelines, and was swaddled with 2 blankets. Looking at kind of that double bed kind of being shared, kind of co-sleeping with 1 or both parents, we can see there we've got kind of 7 cases, which is obviously the highest amount of all the 12 cases we're looking at today. And only 1 case was in a Moses basket. Again, we know a Moses basket is a safe place to sleep, but really interestingly, obviously for this case, that unfortunately this baby wasn't sleeping on a Moses basket mattress. They didn't have a mattress, so they used 2 kind of small little sofa cushions. So sadly that baby didn't have a flat surface to kind of to sit on, to sleep on, apologies. And we had 1 case that was actually in a next to me kind of crib. So I'm just going to pause there for a second, and just looking at that location of final sleep, just wanted to see if anyone kind of had any comments, or if anything kind of came to mind to anybody. I don't know, do people find that data surprising, kind of expected? Just wondered if anyone felt they wanted to come on and say anything.
I think we've got Anna in the chat who's raised an interesting question. She said the mattresses of co-sleeping parents, were they assessed in terms of firmness? No, but I think the kind of guidance is, if you are going to co-sleep, is to ensure that the baby is sleeping directly onto the mattress and not sleeping on top of the duvet cover or pillow in the bed with the parents. So making a safe space for baby, where baby can lie directly onto the mattress.
And see, Anthony, you've got your hand up.
Well, it was just to say, Cindy and Jackie, that I think the phrase "the final sleep" is a stark one, and a lot of this is about how we message safety properly, and it just allows the listener to picture the horror and the gravity of it. So just commending the use of the phrase, even though it's emotive.
Yeah, no, thank you, Anthony. And I think that's a really important point, because actually, what we're looking at here is like 12 really tragic deaths in Suffolk, and actually a real positive out today has to come, and which I'll go on just to touch on slightly, is how we can reduce these. And also why it's so important to look at this data is to understand as professionals how we can actually reduce these deaths, because I really believe out of all these kind of 12 cases that we've had, and I think our team are in a unique role to go on the journey with these families to understand their experience, is actually none of these families went to bed on that on that final night and expected to wake up without their baby kind of being with them anymore. And actually probably one of the most traumatic thing that I think these families will kind of ever have to kind of to go through. And I think the person in the chat obviously kind of mentioned about kind of sleeping services there. And I think just going over to when we look at the last bit of data on this slide, kind of looking at the co-sleeping in the double bed, again, what's kind of interesting is out of those kind of cases, 4 was just with mum, and actually 3 cases with mum and dad. There weren't any cases where it was just kind of dad on their own. But as I say, out of those cases, 4 when it was just mum, and 3 when it was just it was both kind of parents. And we're going to go a bit on to kind of the co-sleeping in kind of the double bed in the next kind of slides. But yeah, Tracy, if you're happy to go on to the next slide there. So this is when things get a little bit more kind of heated and kind of the realization. So looking at the risk factors, so you've kind of seen where those 12 cases, what they were kind of looking at. So when we look at kind of risk factors, of those 12 cases, we had an adult in the home smoked. So out of those 12 cases, 9 out of 12, there was an adult in the home who was smoking at the time that sadly, you know, these babies passed away. Even more so, and this message is so important for me for this to kind of to land today, is that of those 12 cases, you know, half of them we can see here, we had you know, 6 of those cases involved in alcohol, and 6 of those cases kind of in you know, drugs. We've got a DA history in 7 of those cases, and in 8 of those cases there was a safeguarding history. And I think this is what's so important, and what we know now about kind of the safer sleep, and something that I feel I can really clearly see, and I really do I can see and believe that actually the safer sleep advice in Suffolk is being delivered well, and for the majority of our families this message is being heard. And I think this data really supports that actually what we're looking at here are the cases that we're left in, you know, with Suffolk, of sadly of these children that die unexpectedly. They are families that have these real high risk factors. So they are using, you know, that they're smokers, and that they are using alcohol and drugs. I think just to break down that term kind of drugs down a bit more kind of firmer, is the majority of those cases it was actually cannabis that was used, and we had 2 cases where cocaine was involved as well. But actually cannabis seems to be kind of a clear relation to these kind of really sad deaths, with either the mum or the dad who was co-sleeping with the baby in the bed with them, or falling asleep on the sofa after having used cannabis. Obviously alcohol also being used in some of those cases, but you can see that 9 of those 12 cases there was a smoker in the house, and we know there is a clear link between that and sudden infant death syndrome. As you can see there, I've kind of put in kind of the kind of domestic abuse kind of history. I say that background, just really understanding where these families, you know, the journey that they've been on, and maybe some of those vulnerabilities. And again, that safeguarding history. So many of these cases of these 12, looking at those, you know, particularly these kind of 6, kind of 7 cases where they have gone into either into the MASH with somebody raising concerns, maybe antenatally, or maybe with the older children, that they've got, you know, either concerns around domestic abuse, or they've got concerns around cannabis use, or that kind of alcohol. Those kind of risk factors were already kind of known and kind of present in these cases. And I think what's really interesting, so I've kind of put there about the social care involvement after death. So when we're investigating these deaths at the very onset of when a baby, you know, dies kind of unexpectedly, it's about that initial kind of assessment of the case and our conversations with social care about those risk factors. And you can kind of see here that of those 12 kind of cases, we had kind of 3 cases where there were no kind of siblings. Of the cases that were kind of left, we've got social care actually for 5 of the cases did actually remove the siblings. Now this is looking back on those cases above. So if you can see, we've really got 6 cases where there were alcohol and drugs were involved, and of those 6 cases, 1 of them they didn't have any siblings, so obviously there was no other children to be removed. But the 5 cases that are left, out of those 5 cases, every time social care have had to remove those siblings. And as you can imagine, absolutely traumatic for these families. They've just had to go through the trauma of their baby, you know, finding their baby deceased, often again involving that kind of co-sleeping in the bed or the sofa, and then at that kind of worst point of their lives, then their other children are being removed. And although I know that sounds the most traumatic and horrific things, in all those decisions, it absolutely was the right decision for social care to remove those children, because these families that unfortunately experienced in this really sad, tragic loss, they all had significant involvement with alcohol, and drugs specifically. You know, they were strong spoken history, and as I say, also kind of current concerns in some of those cases around kind of domestic abuse, but really that there was safeguarding concerns for the whole family that did exist before that child sadly died. But sadly, that child dying does heighten that kind of a risk, and then those children were removed. And we've got Ali Hassi on the call that is going to go into much more detail around the social care kind of role, kind of involving these cases. But I think I just really wanted to put across that really the cases, what we're looking at here, what types of families that are experiencing these kind of a sudden unexpected death in infancy, and really to land that thing. For me, what the biggest thing is, if someone said to me, you know, what can we do to kind of improve this, so we see, you know, so we can reduce our figures in Suffolk, then that really would be that we need to start really targeting the safer sleep advice that we give to these families, because this data for me clearly shows that, you know, without doubt, I really believe that those 6 cases particularly, they were all preventable. These are babies that didn't need to die on that kind of final sleep, and that actually by giving more targeted advice to these families with when there are concerns around alcohol, kind of drugs, kind of smoking, that DA safeguarding history, so that we can change the way we deliver that advice, so that families are starting to hear. So just going on to the next slide.
Before we do, Jackie, we just got a few questions in the chat that I wonder it might be quite good to go to.
Yep, perfect.
So Nicola asks, is there any data on where parents have been given a baby able to hold an object, a bottle of milk, to feed themselves at bedtime? I think most of us were quite young, weren't they?
Yeah, that's actually a really great question, because nationally that is an issue. And there's a lot of kind of promotion, and I know that Lullaby advice, you know, the Lullaby service are trying to do a lot of promotion around that. But actually in Suffolk, I think what you're talking about there is that kind of prop feeding, and that actually that hasn't been applicable in any of our cases in Suffolk.
Thank you. And Cherry just says, regarding social housing, was there any evidence of damp in the home?
Again, another really great question. I would say there was probably only one case where damp was present, but I don't necessarily, in that particular case, it was felt to be a modifiable factor, so something that we could have changed, although it was acknowledged in the housing was so poor. But again, nationally, damp has been a significant issue, and it has been a risk factor. And I'd really encourage that if people are, you know, visiting families where there is real concerns about damp and there is a young baby in the home, then absolutely we should be escalating that to housing, and through, you know, looking at that kind of safeguarding risk, because it does place that baby at significant risk, especially, you know, obviously for our really young babies.
And one question here about, did any of the parents say that they followed close sleeping advice on the Lullaby site? Yeah,
again, that's a really great question. So what I can say quite confidently that all these 12 families all remember being given safer sleep advice. They were, you know, that they can, we'd normally ask them, you know, do you remember what was given to you? And they generally say, we do remember kind of something about that. What we have found is that although they remember being told something, they don't really remember kind of clearly what they were told. And actually often what we find when we ask them, they're thinking about when the baby's put to sleep in the Moses basket on their cot, and about being put on their their back with the covers in the right position, what they don't really seem to be able to kind of remember, or that it hasn't connected with them, was really that risk of the smoking, the alcohol and the drugs and the co-sleeping. That there's only actually, out of those cases, there's only one case that did safely bed share, which I'll mention in this kind of next kind of section. So we've got kind of one case where, as I say, they were safely co-sleeping and they followed the advice from the Lullaby website. All the other cases, actually, it wasn't their intention on the place to sleep. So their intended place was either a Moses basket, a cot, and really sadly, in one case, the intended place was a car seat, which we know isn't a safe kind of sleep. But actually, none of those, bar from one case, that there wasn't any safeguarding concerns. They were safe co-sleeping. All the other ones, it wasn't their intended place to sleep on that final night.
Okay, and there's a few comments in here about the health visiting service. So Joe Howard is going to present around health visiting, and hopefully we can cover some of those questions then. And also some really positive comments about the smoke-free pregnancy pathway that's working really well. So just yeah, some really good work that's been going on there as well.
Yeah, and just touching on that, it's like, just from a real kind of personal note, and I think it's really important that, it's like, we need to acknowledge is that actually in Suffolk, with reviewing these deaths kind of year on by year, we are able to see and evidence that kind of change, and that smoke-free pregnancy is a major thing. You know, when we take these cases to the Child Death Overview Panel and they get taken kind of nationally, the factors that we've been seeing about kind of smoking in pregnancy and smoking around kind of, you know, the newborns and these babies that we're seeing under kind of 5 months, but actually to see that how it's changed over the 4 years to now to have the smoke-free pregnancy, and which I think is really in the last kind of 6 to 12 months is really taking off. I'm really hopeful that we're going to be able to see that reduction in this data kind of from that, because certainly already with some of the neonatal cases where sadly they haven't died of sudden unexpected death in infancy, but they've had these babies that don't get discharged from hospital and sadly die in that neonatal period, that smoking seems to be a reduced factor that we're kind of seeing. So just kind of coming on to bed sharing and the risk of unexpected infant death. So I think it's really important. I just wanted to touch on this because what I really don't want to is anyone. Our data clearly shows that a huge amount of percentage of our cases they were bed sharing with either a mum or dad, or they fell asleep sadly on a sofa. But what we must remember is that the bed sharing with an adult who smokes, has been drinking alcohol, taking recreational drugs, carries a high risk. And that's the message we really need to, for our families to hear, that bed sharing on a sofa or armchair carries a high risk, and that there is a risk of the risk is higher for infants born prematurely or of a low birth weight. But what's really important is that bed sharing with a breastfeeding mother with none of the above risk factors has not been shown to be a significant hazard in any study. What I think is really important is I don't want anybody coming away from this webinar and thinking we should be discouraging bed sharing, because that's not the message. But what I want you to leave with is that in our cases, the bed sharing, that the deaths that we're seeing are from co-sleeping with an adult that has either been smoking tobacco or kind of cannabis, and has been drinking alcohol, or kind of obviously taking drugs on that last final sleep. So just going on to the next slide, just to give you some evidence for you to take away from you. If Tracy, if you go on to the next slide. So this was obviously such an important factor about the bed sharing, and actually the NICE guidelines, which are our kind of clinical guidance in 2021. And I am just going to read this out to you. So the committee agreed that on the basis of the evidence presented, which showed no greater risk of harm when parents shared a bed with their baby compared to not bed sharing, healthcare professionals should not routinely advise parents against sharing a bed with their baby. They agreed about the importance of parental choice in relation to bed sharing with their baby, assuming they follow safe practices for bed sharing. And I know there was some kind of comments kind of in the chat, so I've put the link in there and these slides will come out to you. So this was a review into kind of bed sharing, the national kind of data which kind of was provided to NICE, and when they kind of met, it was really to explore, to check that the advice we're given around bed sharing is kind of correct, because we know that actually there are lots of families that do safely follow safe bed sharing, and our data in Suffolk we've only had one case where a baby sadly died, and it was felt that they were safely bed sharing on that final sleep. However, there is always that kind of other side that we kind of also have to think about tiredness of our parents, and maybe the health of our parents, for any kind of mum or dad that is co-sleeping and who has become very tired over the period of time and not sleeping, what impact that kind of that has. But this is really about being able to educate our families into how that risk significantly increases when you've taken drugs, when you've taken alcohol. And I think what's really important is when we talk about kind of drugs and alcohol, that this is really any amount. For any mum who hasn't drank alcohol throughout their pregnancy and they have that first small drink, that actually that can be enough to change how that parent is able to safely co-sleep with their baby. So just going on to the next slide here. So this was from a bereaved mum, and actually this was the first case that I was kind of involved in, and something that this mum said to me is, and it's always stuck with me, and she said, "I remember being given safer sleep advice. What I didn't realise is that my baby could die if I didn't follow it." And something that why this I think is such an important thing for us all to kind of to remember is that this was a mum and a dad who could remember be given the safer sleep. They used cannabis, they did drink, that they did smoke, but actually for them what safer sleep meant is that baby being in a Moses basket, towards the bottom of the Moses basket with the blankets kind of tucked in and kind of not smoking around the baby. Sadly that baby, mum fell asleep breastfeeding that baby on the sofa. She had cannabis that kind of night, and she wasn't able to relay what that risk meant, that that she increased it. And something that for that mum is that she will forever, and has said to me, living with that guilt of not following that advice is the thing that she struggles with the most. And the one message that she wants to be able to share with people is to it is for us to give a more hard-hitting advice. That she said she just saw safer sleep advice as being given it by a health visitor, that there was a leaflet. She recalls being able to go, being given knowing online, a link to go have a look, which she says she never did, and something that other families have kind of mentioned. But the fact that they weren't able to recognize that by not following the advice meant that their baby was sadly going to die. And I just wonder if actually part of sharing this kind of data with you is to help you with your conversations with families, and to say and to make people aware that babies are sadly still dying. We did some training a couple of weeks ago, and one professional had kind of said that she didn't realize that actually we're still seeing cases of SIDS, just wasn't aware that this was still a thing, and kind of felt since the Safer Sleep and all the campaigns that have been done over the years that actually now this was something that didn't exist. But what we're seeing is now we're just seeing the cases that are left that are really kind of vulnerable. Our vulnerable families, as I've mentioned before, where there are this safeguarding history, where there are concerns around alcohol misuse and kind of drug, and specifically kind of cannabis use. So I'm just going to stop there and see if anyone's got any questions. Feel free if you feel like you want to know a bit more about the cases or the data. Just wanted to give you kind of an opportunity if anyone wants to come in there. So that's fine. So Tracy, if you want to go on to there was a hand. Sorry, I just saw a hand quickly go up there.
Hello, sorry. Yes, just a quick question. I just wondered, and obviously we know that prematurity and low birth weight is a risk factor. Did that come through as any sort of theme in these local deaths that have occurred?
Thank you, Sarah. Great question. And actually, no, it wasn't. It wasn't a theme. You know, these babies that sadly died, these 12 babies were all healthy babies. They were all of a good kind of, you know, weight. You know, none of them had been born prematurely. You know, these were all term babies.
Thank you.
So just going on to the next slide. So we were hoping today to have police to come to give you their kind of police view, but unfortunately they weren't able. So you are stuck with me for another kind of quick kind of section, I'm afraid. So we work really closely with police. So as I mentioned, that when a baby dies unexpectedly, our team and the police will work together alongside social care and our partner agencies to investigate and to gather information. So the most important kind of message, and again, something that when you're visiting or you're having contact with these vulnerable families, when we're talking about safer sleep, is to talk about, as we've seen in Suffolk, we know that overlay is our greatest kind of risk for our babies in Suffolk. And actually, from a police point of view, overlay when under the influence of drugs and alcohol is a criminal offence. So going back to those kind of cases that we've kind of spoke about, so we're looking at now kind of the 6 cases out of that data where there were concerns regarding drugs and alcohol, where social care have removed the siblings at the time of the baby's death due to concerns about the parents' drug and alcohol use, that actually all of those went through what we call a forensic post-mortem, and this is when the police are at that very early stages are exploring that are there criminal charges here. So what we need to think about, we've now, you know, got a mum and dad in A&E who have sadly really tragically lost their baby, and I can really confidently say out of all these 12 cases, none of those parents went to bed on that final sleep and expected to wake up, you know, without their baby. This wasn't their intention. I really believe that there was no intent, but this is safeguarding, and and unfortunately it is a criminal offence if with overlay, and again if there's been drugs or alcohol. So often these parents will be arrested, so they've lost their baby, they've been arrested, and social care have removed their children. I think we can all kind of only imagine how traumatic that is for these families to to go through, and as horrible as that is the right process, that all these organisations you know have this job to safeguard and to take the proper kind of official kind of view. But I do wonder how, when we deliver the safer sleep advice, how many of our families realise that the seriousness of not following the advice on what then those risks are. So as I mentioned, so they will be arrested at the time. Oh, sorry, can we go back one? Sorry. Oh, if you can just go back to the police slide.
Sorry, did it not
No, I think it went forward.
I'm trying to get it to go back. Yeah.
Oh yeah, it's still going
Hang on.
forward, sorry.
There it is.
Perfect, thank you. So so they're arrested at time of death, and those parents will be given bail conditions. So I've just put that on that blood sample. So obviously often the reason why police really need to arrest parents at the time of death is because legally, to be able to get the blood samples, that's the process they need to go to, and that's obviously to gather the evidence. So that's to obviously to assess what that kind of level of kind of drugs or alcohol. Now really interestingly, there was one case where the police decided not to arrest the parents, and they didn't take the blood samples at the time of death. Now they did speak to the mum, and she actually consented to giving the blood samples, but her partner spoke to her and encouraged her not to, to withdraw her consent, which she did do, and the police accepted, and those blood samples weren't taken. Now what's really important about that point is that this mum, for her, and something that she shared with me later on in kind of this assessment kind of review period, is that her biggest regret is not taking that blood sample, because she said that would have proved to professionals and particularly to social care that she wasn't under the influence at that time, and she felt that actually having taken that blood sample would have been able to prove and would have helped her in being able to get her children back in her care. So sometimes it can be a really positive thing. It can provide, you know, not just evidence for police, but it can also support kind of, you know, parents with any police or social care investigation. And just kind of touching there on, which is important to understand what these families go through, is that looking at, you know, concentrating on that kind of those 6 vulnerable cases where they had a forensic post-mortem. Is a long wait for those results. Some of these cases have taken 18 months to 2 years to kind of for all the information to be collated and for police to make a decision if they're going to take it to the CPS, which is the Crown Prosecution Service. We then have to wait to see if CPS are going, if they feel there's enough evidence to then to take the parent to court and to charge them with neglect or with, you know, the criminal offence of overlay. And just to kind of to understand the timeline, so when we're looking at those 6 cases, we have had 3 cases kind of completed. They went to CPS, but it was decided that it wasn't in the public interest for those cases to be taken to a criminal kind of into a criminal court. The other 3 cases are still going through this process, and we're still awaiting an outcome. And just there kind of like the police kind of coroner role. So one message that police really wanted to kind of for me to share today is one that I've already kind of mentioned, and I hopefully that's really landed, is about overlay being a criminal offence when under the influence of drugs or alcohol. And the other thing that police really struggle with is when they're involved in these cases, they are guided by their kind of police kind of guidelines and their contact with parents, because they're actually, it's all about kind of evidence for them, and they have to be really careful of when they're speaking to parents and to family members. So their involvement in these forensic cases are different to when police are involved in other cases, these other kind of sudden unexpected death cases, and for our other child deaths where actually ourselves, our team and police often will do lots of joint visits together. We kind of work the case jointly. In these cases where police are taking, you know, a criminal kind of viewpoint, they have to be very strict, and they tend to rely on us to continue to be that kind of key point of contact for the family, to offer the support, because the police end up moving into having a conflict of interest, and they have to take a much more kind of formal role. So I don't know if anyone, and so apologies again that we didn't have anyone from police here, but happy to answer kind of any questions that you kind of have regarding that kind of police kind of view with the sudden infant kind of death cases. No, so I think when now, if there's nothing in the chat, I just want to check, Cindy, if there's anything in the chat, sorry.
I've tried to be answering the chat as I've gone along, so hopefully I've covered things, but we'll go back to it at the end in case I've missed anything. So just some interesting conversations about cannabis use and what that actual risk is, and some conversations about medication that is prescribed, so not just that's sort of illegal. I think the general consensus of what people are replying, what I've replied, is around that kind of inability to rouse quickly. It seems to be the issue when bed sharing, having taken something that's going to make you sleep a bit deeper.
Absolutely. I'm just going to hand over to the next section, which is over to Ali Hassi, who's going to talk to us about the CYP kind of involvement.
I am. Jackie, can you hear me first of all?
Yes, we can.
Perfect. Okay, because I'm in a county council building, but I can't connect. So I'm actually talking to you through my phone. So if you can hear me, that's a really good start. Anyway, good morning, everybody. I'm Ali Hassi. I'm head of children's safeguarding with Children's Services. And within Children's Services, I hold the portfolio for child death. And so therefore I sit on CDOP, and I also review some of these cases along with colleagues, the ones that go through to case review panel. So I've just got a relatively short presentation, and I have to apologise because my slides are not anywhere near so eye-catching as my colleagues. When I got the deck, I thought, oh goodness me, I need to do better next time, but hopefully the information is still there, and that's what's important. For any social workers who are on this webinar, some of you will have heard some of this information at the pre-birth assessment webinar that we did within social care just a couple of weeks ago, that Maureen Roscoe-Goulson presented. And in addition, I just want to promote the audit that was completed earlier on this year, because again, some of this information is within that audit. So it would be worthwhile having a read of that if you can get hold of that. Okay then, so supporting families to have safer sleeping practice is not just a health task, it's a multi-agency responsibility. So it's something to think about for social workers when we're undertaking pre-birth assessments, when we are holding family network meetings, when we're in SIM meetings, core groups, and any other interaction really. Safer sleeping practice needs to be integral to a pre-birth assessment in the same way that we might consider other factors. So for example, like the parent's own experience of being parented, criminal history, mental health concerns, prevalence of drugs and alcohol, history of DV, all those domains that you will look at. Safer sleeping needs to be considered within that. And then safer sleeping planning, if need be, should be part of the plan for the baby. So it's on the forefront for parents and those in the network who can support the parents with their safer sleeping practice arrangements. So the audit that I've just referenced that Maureen Roscoe-Goulson undertook earlier on this year, it looked at 40 babies open to children's services as unborns, and identified evidence in just 11% of those cases where discussions had taken place with the parents about risks to babies when sleeping. But of those 11%, actually none of them went on to talk about anything within the plan. That doesn't mean to say there wasn't that discussion, but there's only evidence in 11% of those 40 cases. So thinking more about risk assessment, we've got a comprehensive pre-birth assessment tool that you'll all be aware of as social workers, that really helps to think about the parents' experiences of being parented, and also things like the impact of drugs and alcohol upon the capacity to parent. And this is a really good opportunity to visit with an expectant parent what their knowledge of risks are to a baby while sleeping. You'll know, and Jackie has just really emphasised this, that whilst co-sleeping can be safe, if a carer is using drugs, illicit or prescribed, or is under the influence of alcohol, the risk of death to the baby increases, and it's significant risk. So therefore, if there is a history of drug and alcohol use by the parent, this really needs to be probed. And we know that perhaps through fear, or sometimes through wanting to manipulate, a parent may tell us they don't use drugs anymore, they don't drink anymore, or they won't drink when the baby comes along, things like that. You'll have all heard it. But the cases where we have seen where a baby has died, drugs and alcohol has been a feature, and we've understood that it wasn't problematic. So families still need to be informed about the risks, even when they are telling us that drugs and alcohol is not a feature in their home. And it's important that they still are aware, and we continue to probe sleeping practices with the parents and obviously once the child is there as well. So just a little bit about situational risk. So some families are transient. They may not have a home of their own at the time that the baby is born, and effectively sofa surfing, or they may be staying temporarily with friends or family, meaning that sleeping arrangements for the baby are more ad hoc. And again, it's so important that those arrangements, and crucially the sleeping arrangements for the baby, are properly explored prior to the baby's arrival. Involving the network would be good too, so that everyone who's in that child's circle, so I'm thinking about grandparents and aunts and uncles, are aware of the sleeping plans for the baby, and they know what's safe and what's unsafe, so they can support the parents with implementing good, safer sleeping practice. Tracy, could you just move on to the slide, please? There we go. Okay, so once the baby is born, good practice is for a pre-discharge planning meeting to be held, where again, is another opportunity for those proposed sleeping arrangements to be shared and checked out. And it's an opportunity to impress upon new parents or parents who've previously had children the importance of safer sleeping practice. And I'm aware the Suffolk Safeguarding Partnership are in the process of bringing in a pre-discharge planning meeting protocol, which we've not had before in Suffolk. And it's not just for children who are on a child protection plan, but babies on a SIM plan can also be subject to the pre-discharge planning meeting. So following the birth of the baby, when undertaking home visits is a good time to check out that the family are doing what they say that they would be doing. So asking where the baby is sleeping during the day, during the night, who's doing the night feeds, and how. It really helps to build a picture of what that sleeping practice is looking like, and triangulating that info with the network, particularly if they're staying with family or friends, and with both parents, so checking it out with the dad as well as asking our health colleagues, will again support an emerging picture and will feed into that ongoing assessment now that the baby is with us. It's important that we as practitioners keep up to date with current advice for safer sleeping, and sometimes it can change quickly. And I'm always minded by my own. I've got 14 months between my daughter and then my twins. And between those pregnancies, the advice has changed around safer sleeping. So it's really important to check with health colleagues that we as social workers are giving correct advice and making sure that it is current. So we can check that out with the parents as well, that they do have that up-to-date advice. But being mindful, and I saw somebody in the chat much earlier on talking about gaining trust and respect, but being mindful that it is tough becoming a new parent. They've got lots of things to remember, so we must be teaching and supporting rather than preaching. So I think it's going to appear in Joe's presentation shortly, but health visitors sometimes use a risk assessment devised by Kent that some health visitors are using in Suffolk, although we're looking to devise our own. So it's for use once that baby is born, but become familiar with it. Ask your health visitor colleagues to see it. Have they carried out one for a particular family that you're working with? But there are also some domains on there that you can be thinking about and can be talking to the family about before the baby is even born. So, for example, if there's a twin or triplet pregnancy, the risk increases. If we know that the baby's going to be a boy, for example, again, there is a slight increase in risk. So do ask to have a look at that and use it as part of the pre-birth assessment planning as well. So as I said, my presentation is rather short. I hope there are things in there though that will help you think about your pre-birth assessments and what you need to include, and think about that safer sleeping practice, because it can be a safeguarding issue. Some families will absolutely be doing the right thing, really listening and implementing that advice that they've been getting. But for some families, they do find it more difficult, as you know. So please make sure that we are thinking about it in those assessments and thinking about it at where it needs to be as a safeguarding issue. Okay, right, I'll go back to Cindy, who's just appeared. Thank you.
Annie, just to say that there's a question in the chat saying, could they have a copy of the audit? Could that be shared? The audit that you mentioned.
Is it from a social worker? Because that will be.
It's from Lisa Page, who I think is Family Nurse Partnership. So.
Right, Lisa. Yeah, we'll get that. We'll get that to you. That should have gone out wide and far to social workers, but yeah, no problem at all.
Thank you. I think over to Jo now.
Hi, good morning everyone. My name's Jo Howard. I'm one of the named nurses for the 0 to 19 Healthy Child Service with Safeguarding Children. I'm just going to talk a little bit about the role of the health visiting service in relation to delivering safer sleep advice. So I'll just turn my camera off while I'm presenting. Our involvement with families starts in the antenatal period, and the level of service depends upon families' individual circumstances. So I have seen already, in the chat, we've talked a little bit about this. So not all of our contacts are face-to-face or within the home environment, and some contacts take place within community settings, such as the family hubs. Some are telephone appointments. And I'm aware that the 12-week contact isn't currently being offered to all families. But I think that the key thing is that whatever the contact, our role is crucial. So talking to families and supporting them with understanding how to avoid specific risks for their baby, we can help to reduce the number of babies that are dying, and this applies to all professionals, so not just the health visiting service. So, you know, social workers, midwives, GPs, even nursery staff, childminders, you know, and so on. We all have a role to play in keeping babies safe. Can I have the next slide, please, Tracy? So, safer sleep needs to be discussed with all families, regardless of their circumstances. And this is something that we do really well within health visiting. So it's so important to have open and non-judgmental conversations with parents, carers in relation to their choice of sleeping environment for their new baby. If parents choose to bed share, then it's important to understand the reason for this and explore how it can be facilitated safely. Ideally, to be able to observe the sleeping area with consent where possible. Lots of parents are often happy to show you their new baby's sleeping environment and the things they've bought and so on. And that obviously can allow you to identify any potential risks. Tailoring the advice and support to the family's individual circumstances and their home environment. Also being able to explore the sleeping arrangements should baby be cared for by family members in another environment or during trips away from home. So, you know, that's particularly important this time of year with Christmas fast approaching. You know, often we all have a change of routine and families go and stay with relatives and so on. Also recording conversations and the advice offered is really important, so documenting it on System 1 and within the parent-child health record, and just confirming that parents, carers are understanding the advice that is being offered. Can I have the next slide, please, Tracy? So there are some key messages and key advice for parents and carers to follow, which we're all aware of, and we've already covered these a little bit already. So back to sleep for every sleep really is the simplest message, and since I think around about, I think Cindy said, I think it's the 1980s, the big drop in SIDS deaths has largely been attributed to the success of this message. Also, babies need to be placed on their backs in a feet-to-foot position for every sleep, in a, you know, on a clear, flat, separate sleep space, which is in the same room as parents or carers, ideally for the first 6 months, and that's both day and night. In relation to bed sharing, as we've already heard from Jackie, there's no need at all to routinely advise parents against sharing a bed with their baby, as long as they follow safe practices. But bed sharing is extremely hazardous for infants if parents or carers have consumed alcohol, if they smoke, if they've taken any drugs. And I think, again, it's already been included in the chat, but that does include prescribed medication, which could affect awareness or make them sleepy. Also, if babies are born prematurely, so less than 37 weeks gestation, or if they weighed less than 2.5 kilos at birth. It's also important never to sleep on an armchair or a sofa with a baby. That can increase the risk of death by up to 50 times. And again, there's lots of things on the market, you know, that we really shouldn't use. So pillows, bumpers, quilts, pods, nests. I was thinking of sleep positioners, you know, all sorts of items that, you know, can make a sleep area look very welcoming, very pretty, but actually are really hazardous. Other key advice, I think, is making sure that baby's head is uncovered so they don't get too hot, and also maintaining the room temperature to sort of between 16 and 20 degrees. In relation to breastfeeding, the incidence of SIDS is halved in babies who are breastfed for at least 2 months. And of course, we, you know, promote breastfeeding. And it's also important to keep babies smoke free, again, both day and night. Next slide, please. So this is the risk assessment tool that we're currently using in Suffolk. This was originally created by the Kent Safeguarding Children Board. It's available on MySCC and the Suffolk Safeguarding Partnership website. It's not a tool that we're routinely using. It's really only when practitioners have identified a family's risks for SIDS to be high, and then it's something that can be used in partnership with parents. However, as part of this process, we are looking at other things, as Ali said, we're looking at other thinking tools that could be used to support practice, and also looking to update the best practice guidance and develop a best practice guide. The next slide, please. So I've just included the link to our health visiting website at the top there. There's lots of information and videos on here that we can signpost parents and carers to. I've also attached page 11 of the parent-child health record. So that's a really good reminder of safer sleep advice, and that can be flagged up to parents by all professionals. And also it includes the website address for the Lullaby Trust, which is an organisation raising awareness and providing expert advice on safer sleep for babies, and they also offer emotional support for bereaved families. Next slide, please. And so I just thought I would finish on sharing a little bit about the Care of the Next Infant, or the CONI programme in Suffolk. So working alongside the Lullaby Trust, we have 12 CONI champions across the health visiting service who are able to offer the programme to parents who are expecting a baby and meet the referral criteria. So either parent has experienced a sudden infant death in the last 2 years, if the child has experienced an apparent life-threatening event, or if there's been multiple births where one child has died from sudden infant death syndrome, but the others have survived. So the programme can offer regular contact to allow families to discuss any worries they might have, can offer training on basic life support, a symptom diary, a room thermometer, and the Lullaby Trust also provide a movement monitor to pick up movements as baby breathes. And that's all from me. I'll add a link to the chat from the Lullaby Trust. There's a really good resource, Safe Sleep Saving Lives Guide, which is for professionals. So I'll just add that into the chat. That covers a few more things like swaddling and dummy use and so on.
So kind of, sorry, my throat's going now. So yeah, so on the screen, kind of just on the slide before, there were just some links that when you get the presentation, the first kind of links are really the National Child Mortality Database. So that is the organisation that when we do the child death reviews in Suffolk, all the information collated from the reviews gets fed into that national system, and they're the ones who review all the deaths across the UK, and they're where they've come up with these thematic reports, and they're really interesting. The ones that we've kind of shared are the ones where there's a direct link in their reviews to do with the sudden unexpected death in infancy, and I have also put that nice guidance on kind of safe bed sharing. As I said before, some really interesting national data, and at the very bottom there, as kind of Joe kind of said, you've got the Lullaby Trust. Now, from the National Child Mortality Database point of view, the Lullaby Trust is without far doubt the key agency where we should be referring kind of families to. They've invested a lot of money in resources to make that easy read for different of the difference in our kind of client groups, and they've got some really great YouTube videos where you could actually, if you're concerned that maybe some families aren't able to maybe take on board what we're saying in our verbal form or with a leaflet or signposted, and those kind of actual video links are a really good kind of visual aid. They've done lots of different videos covering different aspects of the safer sleep.
I think we've just got a couple of questions in the chat for Joe, actually. So one is from Amanda saying, is the CONI programme not available if it's longer than 2 years since the infant had died?
Oh, you're on mute, Joe.
Sorry, I only just realised that. I think it differs nationally, but certainly in Suffolk, that's our referral criteria that unfortunately it's within the last 2 years.
Okay, and one more, really just saying, where could they find the names of the CONI leads in our area?
I could find those out and I could share those if you'd like me to following this. I mean, referrals need to go through the Health Business Centre and then they are allocated to that CONI champion within the local area. But I could, so it would be through the Health Business Centre really that all referrals need to go, but I could find out the names if you'd like me to.
That would be great. And does it cover the whole of Suffolk?
Yes, as far as I know. I don't know if is Sarah Edwards on the call? She's currently leading.
Okay.
But yeah, no, as far as I know, it covers the whole of Suffolk.
Thank you.
And I think, Cindy, so just carrying up on the CONI side, is I did have a conversation with Ali Brett, who's our bereavement midwife in Ipswich Hospital, and I know she's currently trying to request some funding to get some more kind of monitors, you know, for the safer sleep, that kind of, you know, the alarmed monitors. So she's kind of looking at that at the moment. So also would encourage it if anyone's got any kind of families, that you could also tap into the bereavement midwives at the hospital.
I'm absolutely sure I haven't covered everybody's questions that have come up in the chat, but what we'll do is we will have these questions on here, and we'll perhaps pass them on to the relevant people, the ones that are outstanding, and get some answer Q&A back to you if that's okay. But has anyone got any questions that they'd like to ask now by putting their hand up? We could try and cover them. Oh, I can see one hand. So, Joe?
Sorry, struggling to unmute there. Yeah, I'm an OT who works with babies and children with complex neurological conditions as part of my work. And I just mentioned it in the chat that I've been to the Lullaby Trust before and asked the question about the fact that some of the babies that we work with can't go by the usual advice, so sleeping on their backs. Some of them, that's a huge aspiration risk for them. So there are baby positioning systems that have been tested, and obviously we ask the questions of the companies that provide all of those. But I just think it would be a really amazing piece of work if kind of community therapists and the Lullaby Trust and the companies that make these baby positioning systems could all do some work together to have some advice on this, because I realise it's such a specialist, bespoke area. It creates an awful lot of complexities, and those children are also those that have a lot of associated movement patterns if they're just laid flat on their back as well, so they can't settle in the same ways. They've often been in like neonatal intensive care where they've been beautifully swaddled and then come home and it's kind of lay flat on your back with no support, and their brains can't kind of help them organise, kind of bringing hands in and those sorts of things.
Yeah, Joe, that sounds like a separate piece of work but
That'd be huge, I think.
Yeah, but certainly a worthwhile conversation to have, and I know we have local reps from our Lullaby Trust. Maybe if we could think about that after. I mean, thankfully we haven't had any cases like that where we have had a child in Suffolk die who's had a condition that meant that they weren't able to sleep on their back, and that's really fortunate. And I think that goes to show that maybe all of the other risk factor advice is being given, which is also really reassuring as well. But yes, it would be good to see whether we could just get something. It must be very anxiety provoking when these messages are given to parents and they know actually they just can't follow them for their babies. But hopefully we'd be able to kind of give some individual advice in those cases. I haven't really answered your question, Joe, but I will kind of have a think about it, and maybe we can find the link for our local Lullaby Trust and have that conversation.
That'd be great, thank you.
Chloe, I think your hand's up.
Hello, can you hear me all right?
Yes, we can.
Can I just ask you why low birth weight babies are a risk? Why is that a risk factor?
The low birth weight, did you say?
Yeah, what is the significance of being a low birth weight baby that makes it at risk? I understand prematurity status. Why is low birth weight?
A good question, and not one that I think I can answer. Certainly within Suffolk, we haven't seen that within the cases that we've had, but nationally it definitely has been raised as a risk factor. I can only assume that you know, a low birth weight baby perhaps maybe is more likely to struggle and not to thrive as much, maybe be more susceptible to perhaps picking up different illnesses. But I would have to go back to a national authority on that. We do have links with the NCMD. We could ask that question of Vicky Sleep, who does, she's from the NCMD and she does quite a lot of research along with her colleagues. So we could ask that question of them and maybe get you a more definitive answer, Chloe.
Thank you, thank you.
I can't see any more hands. Oh. Magdalena?
Hiya. I'm not sure. I don't think anything was mentioned about like animals at home, because I know that quite often like parents let like cats or dogs like snuggle with the babies and stuff like that. Is there any like a guidelines or any advice for those parents who actually own like animals, or there is no any information about that?
It's never been raised as a risk factor, as far as I'm aware, either locally or nationally. I would say that if you were working with a family where you knew that they were allowing family pets or pet to sleep in the same surface, same place as the baby, then to advise about, you know, the risk that could cause. But it would be a risk in the same sense as other things within the bed area. So like, you know, your toys or your you know, your bumpers and things. I would imagine that. I don't know, Jackie, I don't know if you're able to answer that anymore. I've not seen it ever raised as a risk.
Yeah, no, I think nationally there have been some concerns maybe raised of like cats. I think traditionally kind of maybe cats curling up in Moses baskets, and you know it's kind of then that kind of suffocation kind of risk. But I think we generally through all services give much more clearer advice on you know, animal safety regardless of the animal. So nationally we're not really seeing a picture with linking to SIDS, as Cindy says, that there haven't been any kind of cases kind of raised to us about kind of SIDS linked with you know, accidental suffocation from an animal, for example. But I think that's probably more to do with, I think there was historically concerns, but I think we're much better at giving animal safety advice.
Thank you.
Okay, I think that's it then. So I don't know, Tracy, if you wanted to say anything at the end, or
just to say thank you, really. That was great. Thank you very much. It was really useful. And I will, send the slides to everybody, because the list of people who attended will come up, the slides and the link to the webinar on YouTube once it's on there. Yeah, but great. Thank you very much. That was really helpful.
okay, lovely. Well, thank you, and thank you all for coming, and thank you for everybody who has presented today as well.
Thank you. And just to say that I'll stay on the